Thanks very much, Anmol. Next up, we have Dr. Hamish Fraser. He's an assistant professor of medicine at Harvard Medical School and a research associate at Brigham and Women's Hospital. For 10 years, Dr. Fraser has been director of informatics and telemedicine at Partners in Health, and along with colleagues from the Regan Street Institute and the South African Medical Research Council, Dr. Fraser is co-founder of OpenMRS, an open source medical record system for use in developing countries. Dr. Fraser.
Thank you. And thanks very much for inviting me. It's a really exciting conference and some very interesting new things. I just want to talk about something slightly different. I'm going to cover really three things. One is OpenMRS and some of the other technology platforms and how they actually can work together to create more integrated views of the information, particularly for clinical care as well as surveillance. Secondly, to talk about a particular application of the system that's relevant to surveillance. And then thirdly, to talk about the rather critical, and certainly in my opinion, issue of how do we actually evaluate these systems and find out whether they're actually benefiting patient care or surveillance, and how good is the data, whether they're actually scalable and so on. So OpenMRS, as Clark was saying, it's an open source electronic medical record system platform. We developed it starting in about 2005 as a way of creating a common platform for collecting clinical data across a whole range of diseases. Although a lot of the work of the system at the moment is actually around HIV care, particularly around PEPFAR and Global Fund programs. It's also used for drug-resistant tuberculosis, for heart disease, primary care, and we now have projects working on oncology and diabetes and many other problems. So the system is designed around a concept dictionary, so it's flexible, allowing you to add a lot of different kinds of data without changing the underlying database. And it's also modular in architecture. And we're working with a project called SMART, which is actually a US government project initiated to create modular components for EMR systems so that we can actually have people innovate and develop new components rather than being kind of tied to one very monolithic platform. And so I think one of the issues about this type of work is that it's been an interesting project figuring out how to actually create a collaboration with many partners in the US, around the world. We have many programmers now in Africa, in Asia and Latin America, all working on the system, and many of them actually making major innovations. So it's not just like a project that came from one group in the US or from one major technical institution. And I think that's a very important issue in terms of the scalability and sustainability. There are a number of different mobile platforms linked to us, so don't tell Trishan that we have other partners. But as well as SANA, there's also the Open Data Kit, which is a University of Washington and Google-initiated project. There's ComCare, which is actually started by a colleague, Neil Lesh, but is actually kind of mainly hosted from Damagi, a company in Cambridge. Does a lot of international health work and also work in the US. And there's also the OpenX Data project, and some of our colleagues working with us in Peru are actually collecting data for a big clinical trial using OpenX data and sending that to OpenMRS, for example. So one of the areas that I've been particularly interested in is how do we take the model of an EMR system, which was primarily focusing on HIV, and broaden that to cover other technologies that are coming up, more lightweight, low-power devices, not only cell phones but also netbooks, using the GPRS and other data networks to actually link together information systems in separate clinics, but also to tie those firmly into the larger health system. And we have the privilege of working with the team in the Rwandan government, led by Richard Gakuba, who are actually working on a national e-health architecture, which links everything from text messaging from community healthcare workers to EMR systems, including OpenMRS, and also national systems for providers and facilities and patient registries and so on. And one of the key issues has been to look at, can we go from a more chronic disease-focused model for collecting clinical data around HIV and TB and so on, and also focus on every patient visit that comes to clinics. And this is one, for example, La Colline in Haiti, and this is data from really the last week or so. We've been taking a version of the OpenMRS platform, which includes the ability to collect every patient visit and also tie that into the diagnoses for those patients. We've been doing some work with Baobab Health Systems in Malawi originally about 3 years ago, and then in Rwanda. And so this is sort of the next step, is to really try and collect that data in Haiti and be able to have real-time data on the diagnoses and the problems of these patients and see whether the patients are coming back, and then tie that into the other data which we're going to collect in the community with mobile phones and other approaches. So the third thing I wanted to talk about was this whole thorny question of evaluation. And the work that I've been doing recently has been partly looking at the amount of money that's been spent on e-health systems in resource-poor environments. And we estimate that somewhere between $3 and $5 billion has been spent over the last 10 years. And having done a systematic review of evaluation studies on such systems and then renewed that recently, it's clear there's only really a very small number of effective studies covering a very small proportion of those projects. So we have a lot of work to do to really create a much more solid platform for what actually works and what should be scaled. And so we got together with a group of people in the Rockefeller Bellagio Foundation Center last year in Italy. And it's a bit of a nice place to go, really. So just to sort of match that, I went to Cairo afterwards and caught a range of very interesting diseases that are not really dreamed of any of the algorithms here. So we've actually put together a group of people who are very enthusiastic about how do we actually create this evidence base. And there are a number of key principles that we're focusing on. They include the fact that there are underlying core principles to the systems that we're developing and using, and that it's not really tied to just one system, and we need to identify those and really scale the most effective parts of systems. And, of course, the thorny question of how do we get high-quality data, and something which we need to revisit every single day, because otherwise, the systems that are developed, I mean, even in a more developed context, can be really problematic when you come and actually look at the data. So making sure that data is used every day by the clinical team, by the management team, by the people actually caring for patients or monitoring diseases is, I think, one of the critical factors there. We also want to foster a culture of evaluation, and that includes developing effective training for up-and-coming evaluators all over the developing world so that people can answer their own questions and that they can really focus on a whole range of stakeholders, not only maybe the funder or kind of an external academic approach, but the people who are actually caring for patients, the people who are managing the projects, the people who are doing supply chain management, who need to ask their own questions. We also want to make sure that we address the questions across the whole range of projects, from the early stages of actually identifying what are the key clinical or pragmatic issues that need to be addressed, right through the design and development of systems, through the initial clinical use, but also to look at the question of scale-up and long-term use, and whether there's an impact when you actually have these systems in place beyond the initial sort of push to get them out there. We are very focused on getting objective evaluation data, so actually outcome data, looking at the patients, whether they're actually showing a clear clinical benefit. But you can't do that unless you actually do a good job of the earlier phases of monitoring the systems, making sure that they're running every day, having built-in technologies, for example, just to tell you if the system's down or if there's a small number of forms been entered this week or if there are problems with data quality. And we're working very closely to make sure there's country alignment, so the Ministry of Health and the other key institutions in countries are actually making decisions about this and really being able to ask those questions. And finally, there's a question of making sure that the quality of studies is good and that we really focus on promoting guidelines and standards for both the design, implementation, and also for the reporting of studies so that we can compare the outcomes between different projects, which has been a particular problem with the studies we've seen published up to date. And so a few more things we're going to do. One is developing a repository of tools and studies and frameworks and teaching materials. And this we're doing actually in collaboration with the Mobile Health Alliance and Patty Michelle, who runs that, and working with WHO as well to collect materials, so that there's a widespread access to this kind of materials. We're looking at a number of different frameworks, including GEPHI, which is a framework for evaluating e-health systems developed in Europe, but actually a very practical set of rules, and comes actually with STARE-HI, which is a guideline for how you actually write the papers and assess the quality of studies that are reported in the literature. And also PRISM, focused very much on the quality of data and collecting data for routine health information systems. And KDS, which is another project from some colleagues in Pakistan and Canada. And we're also advocating, of course, to the funders, because there's a big question about why it is that all of these projects are being implemented, and there are some definitely important things being seen on the ground. We've seen a handful of randomized controlled trials related to, for example, text message reminders for managing drug adherence for HIV patients, or for improving malaria treatment in Kenya, targeting the providers. But we've seen very little evidence that these type of processes are really impacting on care yet. And we feel it's very important that the funders, when they're looking at projects, are both looking at what has been shown so far, how can we take existing technologies and improve on them, so we're generalizing scalable, more cost-effective tools, and then thirdly, to make sure that they don't fund projects that don't have an evaluation component, even if that's a fairly simple thing, like just showing the quality of the system in place in a challenging environment, or some key aspect of the quality of data. Thank you.